other questions, okay, that, or the other topics. We are not seeing here the questions, huh? I prefer to show topics rather than questions, because when we show questions, students tend to write down the question. Let me write this question down. You're never going to find that question again, at least in that form, no? So what you're going to be tested is on topics. Professor, are we going to have a cumulative exam with all that? Well, that applies to everything. Okay? Resting membrane potential, action potential. Remember the first day we showed you the process of insulin released from the beta cell. That is a depolarization of the beta cell. Okay, what happens in the generation of the resting membrane potential? How cells generate and maintain a resting membrane potential in the typical neuron is -70, it's negative. Okay, what happens? Well, at that moment, most voltage-gated sodium channels are closed. You have tons of leaked potassium channels open, some little amount of sodium leak channels are open too, but you have more cations going out, leaving behind an anion. That's why the membrane is negative in the inside. Okay, there was one question, there was one of the options in one of the questions, maybe it was in this one, yeah, that said there is an equal amount of sodium and potassium leak channels open. If that were true, the resting membrane potential would be 0, and that is not a potential. Okay, a potential means a difference. And if the potential is 0, it's like if you have a battery that is discharged. That is 0 voltage. Okay? So that difference, okay, in electrical charges between the outer and inner membrane is what makes this potential energy. Okay, and the capacity to transmit impulses. Now then we have the sodium-potassium pump, and there were several options. Most important thing is that you remember what is the function of the sodium-potassium pump. It's like someone that is in a gate controlling that things stay where they should be. Okay? If potassium goes out of the cell, it's going to be taken back against concentration. Okay? If sodium enters, it's going to be pushed out using energy against concentration. So it uses ATP, uses energy, okay, to take potassium back into the cell and push sodium out. There was another about the differences in the body fluid compartments, which compartments have more protein, less proteins. Inside the cells we have many proteins, enzymes, etc. In the case of the red blood cells we have hemoglobin. In the plasma we have albumin, we have enzymes, we have antibodies, other stuff. Okay, the place of the body where we have the least amount of proteins is the interstitial space. Okay, that's, remember the interstitial space and the intravascular, they are in chemical equilibrium because they have the same amount of ions. It's an equal distribution of ions. But the most important difference between the intravascular and the interstitial is that in the interstitial space we don't have cells, at least the amount of cells that we have in the blood, and we don't have the amount of proteins that we have in the blood. Because the basement membrane of the endothelium, okay, doesn't let the proteins move. Okay, and between the cells of the endothelium, the white blood cells, red blood cells typically don't fit unless they move by diapedesis, in the cases of the neutrophils migration, etc., in inflammation.
Plus, I remember in the practice quiz test, there was a question that said, what divides the interstitial space, or from the intravascular space? And the answer was the endothelium or capillary wall. There were similar questions. But I kept picking basement membrane. Isn't the basement membrane dividing, like, right behind the capillary wall?
Yeah.
So wouldn't it be dividing the intravascular space and the extravascular space?
But has anything to do with this question?
No, it's because it was in the other quiz, so I kept getting it wrong because it just, that question mentioned capillary walls on the basement membrane. You understand what I'm saying?
Yeah, I understand what you're saying, but I have to look at that question to see what exactly you mean. I have to look at the actual question. Now there is another here, resting membrane potential. And that question was about the role of potassium, okay? How potassium participates in this resting membrane potential. And this has a lot to do with what we were saying before about the amount of potassium and sodium leak channels. The question was asking what is the direction of the movement of potassium. Okay, if you have leak channels and the concentration is greater inside the cells than outside, it's going to move out extracellular. And what is the result of that? Okay, makes the inner membrane more negative. Okay, that's very related to the previous question that we were explaining about that. Now, electrolytes. Now, there are some principles that you can learn or derive, okay, once you learn the basic principles. The simple fact that you have potassium more abundantly inside the cells tells you that, for example, if you have massive hemolysis, or a person, for example, after chemotherapy, in which you have a breakdown of cancer cells, all of that potassium is going to go into the circulation. Okay, something that we have to be prepared. Okay, when you have a patient after chemotherapy, or is having a hemolytic reaction because of a transfusion, etc., or has an autoimmune destruction of the red blood cells, they are likely to have, okay, hyperkalemia that we have to be prepared for and we have to monitor. The contrary happens. Let's imagine you have a patient that was having anorexia nervosa for a long time, or food deprivation for a long time, or a patient who had a very bad anemia as a result of lack of B12 or lack of any nutrient, iron, B12, folic acid. And we suddenly start giving
You want me to leave?
No, it's okay, but
You wanted to leave. You come back at
the application of these principles is simply understand how the human body is normally and what happens when this gets abnormal for any reason. And also helps us find explanation for the findings, okay, and try and give us an idea of where to look for causes when there are abnormalities. Okay, so when you have a patient, let's say, that has hyperkalemia, you need to do a differential diagnosis. Okay, either this patient ate 4 pounds of bananas 1 minute ago, or the patient is having a hemolysis, okay, or the patient received IV potassium, maybe someone tried to murder the patient. Okay, we have to find the explanation. One of the reasons is that. The most common cause of hyperkalemia, who knows what is?
Renal failure?
The most common. That is one. That is the least.
Is it like
Dehydration. Or
feeding? Trauma. Some medication.
overwork.
Who has been here? Medical assistant, phlebotomist. You should know what is the most common cause of hyperkalemia.
Tied to the heart.
And what is it because of what? Venipuncture,
Using incorrect needles to tie.
incorrect needles, applying the tourniquet for a longer time, incorrect gauge of the needle, wrong manipulation of the tubes, okay, etc., 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 excessive squeezing of the muscle, etc. That is the most common cause of hyperkalemia. Okay, so if you have a patient that you have a paper that says potassium is in 6.5, and your patient looks perfectly fine, and your patient is alert, oriented, normal, the heart rate regular, and you make an EKG and it's totally normal, this is just a number. Let's repeat the blood test, okay? Making sure that we don't produce hemolysis. That's the most common cause of hyperkalemia, at least as we see it in the blood tests. So, and what I was saying before, If you have hypokalemia, well, we have to suspect one of the reasons is the body is making too many cells at very fast. Like something we call the refeeding syndrome. Someone that had anemia because of iron deficiency or B12 or folate, and they're receiving treatment, and the bone marrow starts making blood cells. And when you make too many cells at once, you're taking potassium from the blood, and potassium may drop. Okay, refeeding syndrome.
What did you say it was called, syndrome?
Refeeding syndrome. Refeeding syndrome.
Professor, would that happen with phosphorus as well?
With increased phosphate, yeah.
No,
When there is hemolysis,
no, for refeeding syndrome. So patients like malnourished for long
phosphate
periods.
going down, that's not so frequent. Okay, not so frequent. Because we have more phosphate available, okay, in the extracellular fluids than potassium. Okay, we simply need to break down some salts that contain calcium phosphate or something phosphate. Another was cell-to-cell communication. And notice that we divide everything in topics. Okay, when you have a question, it's important to have clear, okay, what is this question assessing? What is the purpose of this question? What topic is this question asking for? Okay, and then maybe translate the question, okay, to more easy to understand terms. If you have a question that says it's a viral infection in one cell, and that cell sends signals to neighboring cells, that is the concept of paracrine communication. Okay, then if that signal goes into the blood to other distant cells, that is endocrine communication. Okay, so this is was a question talking about that. And then the famous substance X, okay, this is talking about, what is the topic? Transport mechanisms, okay? And there were different mechanisms we studied. Simple diffusion, facilitated, active transport, primary, secondary, osmosis. Okay, important to know what is the concept of each of them and examples. And then try to figure out, okay, what cells get in? They get in oxygen, amino acids, glucose, fatty acids, vitamins. They get in everything, alcohol, water. What is the mechanism that the cells use to get that stuff? And how cells get rid of waste, like CO2 and other wastes. Okay, in some cases, it's going to be passive transport, active. And if you have a substance that enters freely, okay, that substance doesn't have any electrical charge. It's a non-polar substance. Okay. Then we have another very related question. Okay, the question was saying ions, okay, cations and ions, okay, when they move following their concentration gradient, okay, that is facilitated diffusion. Osmosis is a type of facilitated diffusion that uses channels, okay, channel waters or aquaporins, and it's a passive process. It doesn't require energy. Important to read well, following in favor of the concentration gradient, not against the concentration gradient, and that would be the active transport. Okay, and those were the questions with more. Not that all of them had problems, but there are some that we needed to reinforce. Okay. And here's the PowerPoint. I think we finished yesterday the endocrine, right?
Yes.
Yeah, I think so. We went even. Yeah, we reached these. Oh, well, let me tell you here, maybe, I don't know if I have told you. No, we got here to the resources. Yeah. Okay, in the resources I wanted to show you, probably I already told you about this great website that is the Calgary Guides. Okay. I probably told you something about this the first day. use this website, please. Okay, try to look at the diagrams they have. Okay, maybe they are a little bit complex, and you can try to produce a simplified version of them without looking directly at them. You look at it, you get the idea. For example, here you have the three components of what we call the hypothalamus pituitary thyroid axis. Okay, and then you have things that stimulate the hypothalamus to produce thyroid hormone. Stress can be cold temperatures. Okay, and try to reproduce that diagram yourselves, trying to make it more simple. Okay, there you have some more ACTH, okay, growth hormone, prolactin, different things.
Is that on the drive?
No.
Canvas.
Canvas.
Hazel.
Okay, so let's take a little bit brief look at the learning objectives. Okay, and you're going to understand how we organize, okay, the physiology. We were talking at the beginning about some basic principles, then we moved into action potentials, different types of potentials. Okay, notice that now we are going to start building on that. Okay, we are going to study the different types of cells, okay, that we have in the cardiovascular system, starting with the heart. Okay, and we are going to continue studying the action potentials. And now we are going to study two types of action potentials. Okay, one action potential that occurs in the cells of the conduction system of the heart. Okay, that allows the generation and transmission of impulses. And then another type of action potential, okay, that occurs in the contractile cells of the heart. And please, I need you to understand something. For me, it would be very easy to sit down there and read the PowerPoint. And I wouldn't mind anything. I wouldn't mind that there was a war outside. Okay, but every time there is an interruption, a noise, every time there is something happening like it is normal in everybody, your amygdala tells, what's going on there? And when the amygdala is on, everything else is off. So after that happens, we have to go back and say, what was I? And maybe I had an idea, and that's gone. Okay, so I know it's very bad to be sitting in a classroom when you need to go to the restroom. Okay, but for that reason, we are a person who can reason and decide, okay, let me go to the restroom before going to the classroom. Okay, if I have a job interview, for example, and it's at 11, I won't get there if I am pink. I will try for, doesn't matter what, I will go to the restroom before. I'm not going to drink water before going to the job interview, okay? And try to do things, try to plan, okay? Let's see. So we're going to study two types of action potential, okay? One, okay, that belongs into the conduction system of the heart, the other in the contractile fibers. Okay. When I was a student at Barry University, for me it was a waste of time to be sitting in the classroom. I am a person who studies and learns when I am alone. in my room. I don't learn in a classroom, I don't learn in a group. So what I would do is sit at the back of the room and study. Okay? That was what I did. Everything except making noises and going in and out. Because I don't want to disturb people. I don't like to be disturbed. I don't want to disturb other people as well. Please. Okay? So we're going to try to see how all this applies to the different phases of the cardiac cycle, how the cardiac cycle works to generate pressure, to maintain that pressure, to guarantee the perfusion of the different organs, and to guarantee the perfusion, okay, of the most important organ that the heart is trying to perfuse, that is the brain, which is a priority for our body. Okay, we are going to see the role of the autonomic nervous system there. Notice how we are retaking concepts, okay, from previous lectures, okay, and that tells you also when students ask me, are we going to have a cumulative test? Okay, it's going to be only cardiovascular or only we are going to have also nervous system? No, sympathetic, parasympathetic. Okay, you have action potentials there, you have nerve conduction, you have things that we have been talking about before. Okay, we're going to also look at the role of these in the generation of the cardiac output and the relationship of different variables in the cardiovascular system, cardiac output, stroke volume, okay, with other factors that appear in the peripheral circulation, like afterload, arterial resistance. Okay, we are going to be working or trying to learn the meaning of many different physiological variables, how they are controlled, how they are regulated, how blood vessels of different types participate in the blood circulation and exchange of substances, nutrients, wastes in the body. Okay, at the end we are going to move to the structures that protect the heart, and also we're going to be talking about the role of different blood cells, okay, in the process of hemostasis, okay, controlling bleeding, etc. Now I have a question before starting. Okay, who can tell me? Simple question. Why the blood circulates?
To transport oxygen, to transport nutrients.
Say that again.
To transport nutrients.
To transport nutrients.
And to pick up waste.
Okay. Why? When you have a question that starts with why, how you start the answer? Because. That's two. I didn't say what for. Or what's the reason, what's the purpose of why the blood circulates. Because the heart pushes it. Why is it? Or who doesn't agree completely? You can,
The heart pushes it.
you can mostly agree or mostly disagree or completely agree, completely disagree.
That's how.
That would be the that would be part of the how of the process. The heart, of course, generates a pressure, okay, that pushes the blood forward, but the blood has to continue.
Yeah. The different pressure in the capillaries.
The difference of pressure, okay, that's the key there. The blood and every fluid in the body circulates from one place to another or moves from one place to another because there is a difference in something. Can be in concentration, like in diffusion, okay, things move from high to low concentration, okay, or in osmosis, driven by the osmotic pressure, or can be as a result of the difference in pressure between two different points. In this case, the arterial side of the circulation and the venous side of the circulation. Okay, if you measure the pressure, okay, at this point, in the left side of the circulation, the arterial side, we can measure it. Okay, that pressure is around 120/80 normally. Okay, the mean arterial pressure there is around 90. And if you do the same at this point, it's around 0. Okay, that's the function of the heart. Generate a very high pressure on one side and a very low pressure on the other side, so the blood keeps moving. Okay, so of course the heart is necessary for that. It's the one that generates that difference in pressure, but also there has to be a working, functioning, patent circulatory system, because if we block that circulatory system at any point, let's say we have a thrombus, an embolus, okay, that we place, say, in the pulmonary trunk. Circulation stops. Doesn't matter how much and how hard the heart pumps. There is something blocking the circulation. Okay, and if we start to, let's say, add fluid, okay, we have around the heart we have the pericardium, and there is a sac. There's a cavity inside the pericardium, between the pericardium and the heart. We start adding fluid there, water, plasma, blood. There is a moment when the pressure of the fluid that is in the pericardial cavity is so high, that is higher than the pressure that the heart generates, okay, during diastole, and the heart doesn't open up anymore. Okay, and that blocks the circulation. Doesn't matter that the heart still tries to pump. Okay, but if the heart is unable to generate or to overcome the pressure, okay, around it, the circulation will stop. Now, how the heart can work as a pump, how the heart does that marvelous job. Well, we have to start with, you can start studying any part, no? But we always prefer to start with the conduction system. The first day we told you this could be seen as the nervous system of the heart. Okay, it's a nervous system, or it's a system of cells that generate impulses, transmit action potentials without the intervention of anyone else. Okay, it's composed by the sinoatrial node. Notice where it's located, in the upper part of the right atrium. Okay, and it's called the pacemaker of the heart because it's the one that typically rules, okay, or determines what is going to be the baseline heart rate of the heart. Typically, auto generates, okay, beats at around 80 to 100 beats per minute. Okay, so if you have a heart with no innervation, okay, that happens when we have a heart transplant. We take a heart from one person, dead person, to another person. We don't connect the autonomic nerves there. Okay, simply the sinoatrial node will start auto-generating a rhythm. And those signals are going to be, okay, transmitted to the atria, okay, very fast. So the atria are going to contract immediately after the sinoatrial node fires. And then we have here a special node that is called the AV node, atrioventricular, that has a very, very, very slow conduction velocity compared to the rest of the fibers of the heart. Okay, so the impulses from SA node to AV node travel very fast, but here these fibers have a very slow velocity, so it's going to hold the impulse a little bit. Okay, it's going to make sure that the atria are completely contracted, and we have pushed blood into the ventricles, and then it's going to release the impulses following these branches of the bundle of His. Okay, that have a very fast conduction velocity. Okay, it's going to stimulate the contractile fibers of the ventricles, and they are going to constrict as a unit. So we are going to have the constriction of the atria, then the ventricles, then the diastole. Atria, ventricles, diastole. Atria, ventricles, diastole. That is how the heart is going to work. Now, it is important that we also remember that there is a system of valves that will prevent that the blood goes back when the heart contracts. Okay? And we have valves between the atria and the ventricles, and we call AV valves, atrioventricular, and we have valves at the exit of the ventricles, okay, that we call the aortic or pulmonic valves. Notice that there is no valve, okay, between the veins, for example, superior, inferior, vena cava, okay, there is no valve between those veins and the right atrium. Or there are no valves between the pulmonary veins and the left atrium. So what happens during diastole? The heart opens, relaxes, and the blood enters passively, okay, from the veins, pulmonary and inferior superior vena cava into the atria. Okay, that doesn't require any valve. Okay, then we are going to have the contraction of the atria. The blood is going to enter into the ventricles, but now we need the blood to continue moving forward. Okay, so before contracting the ventricles, we need to close the AV valves. So when the ventricles contract, we make sure that the blood moves to the aorta, okay, and through the pulmonary artery. And that closure will produce a sound that we can auscultate. Okay, that is the sound number one, S1. And then during diastole, we need to make sure that the blood doesn't return to the heart, okay, from the aorta and pulmonary artery. So we need to close the aortic and pulmonic valves, and that will produce another sound, S2, sound number 2. That's the lap and the dub that we have studied, okay, in the heart. And those movements or those processes occur during the 2 phases of the cardiac cycle. Okay, that simply consists of diastole and systole. Okay, diastole simply means relaxation. Okay, the blood passively flows from the atria into the ventricle. And the systole is when the ventricles contract and eject blood into the aorta and the pulmonary artery. And you have to remember not only the concepts, also the situation of the different valves during the different phases of the cardiac cycle. Something that we simply trying to use common sense. Okay, remember, if you need to move the blood forward, what valves you need to be closed, what valves you need to be open in different moments. Okay, aortic and pulmonic valves need to be open to permit the ejection of the blood during systole. Okay, and the AV valves, the ones that are behind, need to be closed so the blood doesn't go back. Okay, you have there the EKG. Okay, you are gonna study the EKG, okay, as deeply as possible. Okay, this is one of the skills that are very important that you get here. And you are gonna see the relationship between the different waves, segments, complexes of the EKG and the phases of the cardiac cycle. Okay, the EKG contains, or we can see there different waves, a P wave that corresponds to the atrial depolarization. Remember, what we are measuring there is electrical charges. We are not measuring the mechanical activity of the heart. This is electricity that is being recorded. Okay, so when the sinoatrial node fires and the atria, the cells of the atria depolarize, that is what we are getting there. So we could say that that P wave corresponds to the atrial contraction, but that is not reflecting the atrial contraction. That is reflecting the atrial depolarization, the electrical activity of the atria. Okay? Then we have a little segment. It's flat. This person is not dead there. Simply the AV node is holding the impulse. Okay? This little bit of time that the AV node holds the electricity before releasing it to the ventricles, that is it. If you give a medication that slows down the conduction of the AV node, that's going to be longer. If you give a medication that shortens the conduction velocity, that's going to be shorter. If you give epinephrine, it's going to be shorter. If you give acetylcholine, it's going to be longer. Okay, that's how we start interpreting the things that we see in the EKG. There is a condition that is known as atrial fibrillation. Fibrillation is like seizures. The atria, instead of doing this, they are shaking. Okay. One of the things that we don't see in the EKG, we see many weird things in the EKG with AFib, but the only thing that we don't see at all is that. Because the atria are crazy. Okay? That is a normal P wave. So you see like scribbles, but you don't see any kind of P wave. Now, once the AV node releases the impulse, into the bundle of these right, left branches, we are going to be seeing this. Q, R, S. Three different waves that appear together forming a complex that we call QRS complex. You know, if you're auscultating the heart, love dub, love dub, love dub, love dub, you are listening, and you could even picture in your mind every time you hear the dub, this is happening. And when you put your finger here and you feel the love dub, love dub, love dub, love dub, love dub. And when if you even can see the carotid pulsation, dub, 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 R, 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 R. So that is the dub. Okay. Love dub, love. That S1.
So
S1.
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 Okay.
S1. S1. Well done.
So it's
I love it.
not dub.
Okay? Now, what is that, electrically speaking? Because this is not the contraction of the ventricle. That corresponds to the closure of the AV valve and contraction of the ventricle. But this is electricity. This is not mechanical. So this is the depolarization of the ventricles. Okay? That's telling you that if we go back, yes. Please.
You said for the contraction of ventricles, is it just you or is it
The what? The?
you said that it was showing the ventricle depolarization. Are you referring to
The complex.
the complex?
Okay? So this is the P wave, the depolarization. This is the segment, okay, between the P wave and the QRS. Okay? Then you have the electricity traveling down, depolarization of the ventricles. So you're going to have, okay, you have electrodes. You have a wave that is traveling towards the electrode that is producing a positive wave, and then one that is traveling away from the electrode that is going to produce a negative wave in the recorder. Depending on where you have the electrodes placed, it's going to appear differently, positive in one, negative in others. That is EKG, that is not physiology.
Oh, no, I was saying, I didn't see that. No, can you show us here on this? Because we couldn't
Oh,
see it.
you have an electrode here. You can have electrodes here, in different. Electrodes in the EKG are like mirrors. They're looking at the heart from different. You can even put electrodes in the back. Okay? If you put an electrode here, when the electricity travels towards the electrode, it's going to produce a positive trace. And when it goes away from the electrode, it's going to produce a negative wave. Okay? But depends on where you are. They're going to have larger or smaller, more positive, more negative. That's why we need all those leads to analyze the EKG. Okay, so you have the depolarization of the ventricles. Okay? And then we have this segment, SD, and the T wave. All that corresponds to the repolarization of the ventricles. Yeah. That is the repolarization of the ventricles.
So would S be like hyperpolarization?
We
No.
don't see there the
No, that's
S. No, that is the direction of the. Now, what do you think is harder? Imagine you are a cardiac muscle fiber, and you are producing action potentials. What do you think is harder? The depolarization of the repolarization? Repolarization. Why?
You have to start back up.
Why is harder?
Because at that point the channels have to open for energy.
Because it needs heat. Okay. Remember, depolarization is just open channels. There's a lot of sodium here and channels open because of the change in voltage. Now, how you establish the voltage and the electrolytes? ATP has to push sodium out and take potassium in. So when someone has ischemia, no oxygen, no ATP production, what is going to be affected first? The depolarization or the repolarization? What is the first change that we see in a patient with ischemia?
Oh, I see. Wait, tissue change.
That's the reason why.
What was it?
ST segment. We're not studying EKG, we're not studying pathophysiology. Okay? We are going to see the first thing that we see when someone has ischemia. Oh my goodness, every time I walk a little bit, when I run, the T wave goes down. Oh no, I have pain. The T wave is going to go down. It's going to be eating first. Okay? Then what is going to happen? The ST segment may go down, and this ischemia only go up when there is a necrosis of the heart. And that's for the future.
Do you teach EKG?
Why, maybe this is for EKG, but why do you see then, like, ST elevations, like when you are having a heart
Well,
attack,
that's-
like why, or ST depression?
I'm not going to answer that question. You know why?
That's right.
No. You know why? Because I heard a cardiologist the other day in a podcast saying there is actually no ST elevation. ST segment stays in the same place. The rest of the things go down. Oh no, that's too much. That's too much. But we see the ST elevation. But it's, according to this cardiologist, is the entire thing goes down and the ST segment stays the same. That for me is mystical. No, but that has to do with necrotic tissue, and it's going to appear only in the. Remember, the leads are like mirrors. Okay, if the infarction is occurring in one side, or in the septum, or in the left ventricle, or in the lateral wall, or in the inferior wall, you are going to see that only in that place. Okay, it has to do with the necrosis of the tissue. Necrotic tissue is not going to transmit electricity as well as the normal tissue.
But if it's not transmitting electricity, why would you see an elevation?
Because you are capturing, what they say is that you are capturing actually the electricity of the rest of the tissue that is around. Okay? What you have is a paper and something that is recording. It's gonna, that the ink, the thing with the ink is there. So it's gonna, depending on the electricity that it receives, it's gonna move like this. So it's gonna move anyway. It's like, okay, that's. So, we now get to the action potential. And I want you to notice something, that we are in time for a break. Okay?
That's so fun.
And we are gonna come back at 9:05. Okay?
There are so much kids that die in my
Sugar free?
She's sitting 1 month old, starting to celebrate.
Okay, before going to that slide that we have there, let's try to be in situation, what we are going to study. We studied in the past lectures, the neuron action potential. Okay, the neuron action potential is also known as the spike potential because it's many spikes, okay, produced. Okay, can produce them more frequently, less frequently, and is represented by this red drawing there. Notice that it's like a spike. Actually, there is a very fast depolarization and a very fast repolarization with a little bit of a hyperpolarization down there. Now, we are going to study now two different action potentials. One that you can see here with a continuous line, and notice that has like a belly there, like a hump there. And that is the action potential of the ventricular contractile myocytes. or any contractile cell in the heart, just ventricular, but any contractile cell. And we are going to study the pacemaker potential. Notice the dotted line. Okay, notice that this is like a waving potential. You don't see any flat line. You don't see any resting potential. Slowly goes up, slowly goes down, slowly goes up, like waves. Okay, those are the two action potentials that we are going to see now. One is in, I repeat, the contractile cells, working cells, and the other in the pacemaker cells. Okay, and this is representing the action potential of the cardiac working cells, contractile cells. Notice that it has different phases. Starts in the phase 4, which is exactly the same resting membrane potential that we saw in the neurons. Okay, you have there a bunch of explanations, our channels, our different things, but the mechanism is the same. Okay, you have different types of channels. You have the lead channels for potassium. Okay, you have some calcium channels that are called L-type channels. L stands for lung opening. Okay, so you have sodium, calcium channels that are going to be closed there. You have the open potassium channels. That is exactly the same thing as the lead channels that we studied in the neurons. So the combination of all that is going to produce a resting membrane potential that is around minus 90. Remember, in the neuron was 70, minus 70. Now, for your tranquility, you don't need to know any specific details, okay, about this resting membrane potential, simply that it is minus 90. We are not going to study the combination of channels there. There is no purpose for that, at least now. Okay? And you have here on top, okay, the position or the situation of the channels. Notice that you have leak channels for potassium. So basically it's the same. Okay, but it's a bit more negative because of the actions of the other channels. Now, the threshold, okay, for these fibers is minus 7. Okay, that's like we are going like 20 points below what happens in the neurons. Okay, once the cells reach threshold, there is going to be a rapid influx of sodium. Okay, sodium channels open. Up to here, everything is similar to the neuron. You have a spike. That is called phase 0. Notice on top you have a bunch of sodium moving from outside to the inside of the cell. Now we reach this peak here, the positive value. Remember what happens there? We had in the neuron the inactivation of the sodium channels and the absolute refractory period. Well, something similar happens here. Now, the cells are going to have a tendency to the repolarization because we are opening to the potassium channels. Potassium starts moving out slowly, as in the neuron. But now, instead of going down to the depolarization and hyperpolarization, look what happens. There is a plateau. That is called phase 2. And you see why that happens on top? Because we have potassium moving out and calcium entering from the extracellular to the intracellular compartment, something that doesn't happen in the neuron, something that doesn't happen in skeletal muscle cells. Okay, and since you have positive out, positive in, positive out, positive in, the membrane potential is kept stable. And while the potential of the membrane is at that level, it's around 0, the sodium channels are going to be kept inactive. That means that the absolute refractory period of the contractile cells of the heart is going to be up to this level. Almost the same amount of time that the heart takes to contract and relax. Okay, so we make sure that the heart can work properly and that no other impulse can generate another beat while the heart is contracting or depolarizing. Okay, what happens at the end in the red part for phase 3? There we have the closure of the calcium channels, so we can maintain the plateau. Now we have only potassium moving out. Okay, until we reach the resting membrane potential. Okay, once we have the membrane potential back to the level of threshold, okay, now we are going to open up or take the sodium channels to the resting state. So they are going to be closed but not inactive. So if another impulse enters here, for example, in what we call the relative refractory period, another bit may start. And we may have an arrhythmia. Okay, if that happens at that point. Okay.
Where was it?
At the end, the relative refractory period. Okay. So it's more or less, it's exactly the same as in the neurons, but the neurons, you have to take this out, cut and paste it here. Okay, the only thing that you don't have in the neurons is the calcium forming that plateau, but the rest is the same.
Does the calcium ever leave the cells?
Yes, it has to. We are going to study that in study the contraction itself, okay, of the cardiac and skeletal muscle. If you keep calcium there, the contraction is going to continue. Then you have to take calcium out, okay. The calcium that came from the extracellular compartment has to be taken out. And the calcium that comes from the sarcoplasmic reticulum has to be pushed back into the sarcoplasmic reticulum. Now this is the other type of action potential. This is the pacemaker potential. And as we said before, there is no resting, there is no stable line at any moment. Okay, you have some channels, okay, that will let, okay, some sodium and potassium move in and out at the same time, creating this slowly increasing potential, waving. Okay, there is a phase that instead of being called resting membrane potential is called pre-potential. Okay, you have channels that we call phony channels. Remember we talked about this the first day? These phony channels allow some potassium out while sodium is coming in, and they regulate the amount of sodium and potassium that goes in and out in order to simply go stepping up until they reach this point, minus 40. Okay, notice that the resting or the lowest potential is minus 60. For these cells, the threshold is minus 40. At that point, there is a spike, and then it goes down, and the same is repeated. When those cells reach, okay, the maximum, they are going to stimulate the cardiac contractile cells, and we are going to have the action potential in the cardiac contractile cells. That action potential in the pacemaker cells is going to be transmitted to neighboring cells, imagine from the sinoatrial node to the cardiac contractile cells of the atria. So the atrium is going to contract. Okay, then we are going to have the SA node transmitting, AV node transmitting the electricity to the rest of the conduction system, and that electricity is going to be activating, okay, the cells of the ventricles, producing action potentials of the other type, the one with the plateau, in the contractile cells. Now, these pacemakers, SA node, AV node, they are under the control of the sympathetic parasympathetic nervous system. They generate impulses at certain rate. Imagine this is the SA node. This is going to occur from 80 to 100 times per minute, like a beat. Now, if you start adding acetylcholine there, this slope is going to be like slowly, not as steep. It's going to be like, so we're going to reduce the rate from 100 to 70 or 65 or 60 times per minute. If we add epinephrine, norepinephrine, then it's going to occur faster. So we're going to have a rate of 110, 120, 140, because that, okay, the pre-potential is going to occur faster. Okay, it's going to elevate, it's going to reach the threshold faster.
Professor, so that is if I'm understanding correctly, that's the pacemaker action potential is for the SA node?
SA node, AV node.
So then that occurs, and then the other action potential that we saw before occurs in the myocytes.
When those currents are transmitted to neighboring cardiac muscle cells, any cell of the cardiac conduction system, SA node, AV node, bundle of His, bundle branches, okay, all these cells are capable of generating pacemaker potentials at different frequencies. Yeah, but typically the SA node is the one that rules because it's the fastest one. Now, here you have another aspect. Okay, we are adding details to this action potential of the cardiac working cells. And there you can see the representation of the different phases of the cardiac working cell action potential. And you see how they correspond to different phases of the EKG. Okay, there you have some concepts that are going to be very important in pathophysiology. And you're going to see immediately which are the ones that you need now and which are the ones that you don't need right now. So we have here the resting phase. Okay, remember we are talking here about the ventricle. Okay, so if you look at the EKG and you have this P wave, that means that at this point the atrial cells are depolarizing. We are having the atrial contraction, but there is nothing happening in the ventricles at this point. Remember, the AV node is holding the electricity, so the cardiac ventricular cells are at rest. They are simply there waiting. Okay, they have blood inside, but they are not doing anything. And we have this depolarization. This is the moment when the cardiac contractile cells receive the impulse, okay, released by the AV node. So you have the depolarization of the contractile cells in the ventricles. Okay, you have the peak, you have the attempt to repolarize, and you have the plateau. This is the calcium, potassium moving in and out at the same rate, maintaining this plateau. Notice that this part here, the first part until you start again going downwards, corresponds to the absolute refractory period, okay, of the cardiac cells. Okay, there is a concept that you have there that you're gonna look at it, but you're not gonna try to memorize or study now. Okay, that is this little knee here added to the absolute refractory period. Okay, that is called effective refractory period. You're gonna know that it exists. Make a note there that you don't have to study that now. You know it exists, but it's gonna be for the future. Right now, we only need to know the difference between absolute and relative refractory period. Okay, that is this here. Okay, the knee, the effective refractory period is something that we are gonna use in pathophysiology. You now know what is located. Okay, and also we are not gonna pay too much attention now to the supranormal period. That is something that when we study arrhythmias in the future, we are gonna mention, but not for physiology now. Okay, right now I repeat only absolute and relative refractory period. Okay, what is the absolute refractory period? Exactly as in the neurons, but it's longer. Okay, it's a period during which the heart can't be stimulated at all. Okay, and then we have the relative refractory period, that corresponds to the T wave. Okay, depolarization occurs only if a stimulus greater than normal. So it's the same concept now applied to the cardiac cells, and you can see how it corresponds to certain traces on the EKG. The absolute refractory period to the QRS and ST segment. And you have the T wave, the center of the T wave. Okay, that corresponds to the relative refractory period. If you want to read the other ones, you're gonna learn and you're gonna understand why, for example, we need to synchronize electrical stimuli when we are applying a defibrillator to a patient. We don't simply apply defibrillation like in the movies. Okay, you have to wait for the proper moment, but you don't, the device will tell you now. Okay, it's not gonna tell you, it's gonna fire when it has to. You have to synchronize, making sure that you apply the defibrillation stimulus in the moment that it doesn't make the situation worse. Okay, that you actually produce a defibrillation and you don't create something that is worse than before.
Professor,
Mhm.
so when the patient has AFib, for example, the medication would work on the relative refractory period, right? Or it doesn't work that way? Because if you're having like the arrhythmia, it wouldn't be on the period of the absolute refractory period, right?
You're
Because-
gonna try to extend, okay, or delay there are different types of treatment for AFib, because AFib has tachycardia and also has an irregular rhythm. So you can work on regularizing the rhythm or slowing down the heart. Okay, so you can give medication to slow down the heart. In that case, you are going to work on the action potential. Pacemaker action potential, okay, slowing it down, okay, or you can slow down the conduction at the AV. No, there are different types of medications that you can use, depending on what you want to achieve. Okay, they act at different points. So we have seen the different types of action potentials. Okay, now we are going to see what happens after that electricity is generated and transmitted. Okay, how we get that electricity to produce actually a contraction, mechanical action of the cardiac cells. Okay, there is a process that is called excitation and contraction coupling that can be applied to the cardiac cells and also to the skeletal muscle cells. Okay, it's more or less the same type of muscle. It's a striated muscle with almost the same mechanisms. The only difference between skeletal muscle cells and cardiac cells is their size, okay, the number of nuclei they have, and that the cardiac muscle cells are capable of using extracellular calcium, while the skeletal muscle cells can't. Okay, skeletal muscle only uses the calcium that is in the sarcoplasmic reticulum. It doesn't get calcium from outside. Okay, the cardiac muscle cells, when they are going to contract, they get calcium from the exterior. What is excitation and contraction coupling? Simply the linking, okay, of this electrical activity of the pacemaker cells with the mechanical action of the working cells of the heart. Is the conversion of a chemical signal, okay, into electrical and mechanical activity in the heart. But for that we use some contractile proteins. There are many different proteins inside the cardiac fibers. Okay, and we are going to try to understand also the role of calcium. Calcium couples, we call it coupling, the electrical excitation to the physical contraction, okay, by simply moving in and out of the myocyte. Goes for contraction, goes in for contraction, goes out for relaxation. So calcium has to be deactivating these contractile proteins. Something very similar to what happens in the skeletal muscle. In the skeletal muscle, after the stimulation of the muscle, you have the action potential traveling in the sarcolemma, entering into the T-tubules, activating the calcium channels, leading to the opening of the sarcoplasmic reticulum calcium channels inside the skeletal muscle. Here we are going to have something very similar, but we are going to have also the intervention of the extracellular calcium. What are the contractile proteins? The famous myosin and actin. Okay, myosin is the thick filament. If you remember the sarcomeres when you studied in the past, they contain an enzyme that is called myosin ATPase. Okay, it's an enzyme that also uses ATP, okay, to perform its activity. And then we have the actin filaments, which are the thin ones. We have some proteins that are regulatory proteins. Okay, if you have studied the muscle contraction in the past, you will remember, if you studied this process, how calcium binds to troponin, and then troponin changes the configuration, moves tropomyosin from the place, and then leaves the actin binding sites of myosin, and then actin and myosin interact, and we have the sliding of the myosin and actin filaments to produce the contraction. Here we are going to have the same, okay, interaction between actin and myosin, okay, that is typically prevented by tropomyosin. That's why we call it a regulatory protein, that at the same time is regulated by troponin. Okay, and there are different types of troponin. Troponin T, okay, troponin I, and troponin Z. And they have different functions that you can see there, that you can use even some mnemonics to, if you want to remember the actions of the different troponins. The T ties troponin to actin and tropomyosin. Okay, the I inhibits the activity of the ATPase, and the troponin C is the one that binds calcium. Okay, if you want to learn, I'm not going to ask you that, but if you want to know what is that for, there you have the way of learning that. And these are the cardiac markers that you are going to use, okay, in order to diagnose when people have cardiac necrosis. Okay, notice that the different troponins may appear at different moments. Okay, for example, troponin I may appear in 3 to 4 hours. Okay, back. Yeah, and will extend for 4 to 7 days. Okay, troponin T, okay, will appear 3 to 4 hours after the infarction and may be present for up to 2 weeks there. Okay, and then we have the troponin C, that is the cardiac marker, but can be found also in the skeletal muscle. So if we find troponin C elevated, we don't know person had a crush injury or a skeletal muscle lesion. So the ones that we try to use are the ones that are more specific for the heart. And there are interesting questions that you are not going to have. For example, they tell you different cardiac markers. This is elevated, this is normal, the other is it's negative. Okay, how many days ago was the infarction? You have to start like putting together all that. But that's the utility of those tests. Now there is a phenomenon, okay, that occurs in the cardiac myocytes. Okay, that is called calcium-induced calcium release. Okay, this is an aspect of the cardiomyocyte contraction that is important to remember. Okay, and when I say important, I'm thinking always about the pharmacology. Okay, notice that here we have something that is very similar to what happens in the skeletal muscle. Okay, we have let's imagine this cardiac fiber, okay, receives a stimulus, okay, from neighboring cardiac conduction cells. There is going to be a depolarization traveling, okay, along the sarcolemma. There is that the depolarization will open some calcium channels here in the cell membrane, letting calcium from the extracellular compartment enter inside the cells. The depolarization continues down the T tubules, opening calcium channels here as well, letting calcium in, and that calcium is the one that is gonna open calcium channels in the sarcoplasmic reticulum of the cardiac cells. This is similar. If you remember the skeletal muscle, okay, that is similar, except in the skeletal muscle we don't have these calcium channels here. And the opening of these channels, okay, is what is going to open these calcium channels. When the depolarization gets here, that opening, this channel here is focal to that ryanodine channel, and that's what's going to release the calcium inside the skeletal muscle. In the cardiac muscle, there is no link between the T-tubule channel and the ryanodine channel. Simply the calcium that enters from outside induces the opening of the ryanodine channels that will induce the release of calcium from the sarcoplasmic reticulum. That's why it's called calcium-induced calcium release. And why is that important? Because you are going to be giving to your patients medications that we call calcium channel blockers. And that's what they do. They block those channels. not all. Okay, not all of them. If we block all the calcium channels, heart stops.
It doesn't seem as beta blockers. It's different.
Beta blockers, no. Beta blockers are simply blocking the activity of epinephrine. Okay? When you block the activity of epinephrine, if you have the pacemaker potential, let's say this is the pacemaker potential of the heart, of the person, what you are doing with the beta blocker is you are blocking epinephrine activity. Okay, so you're going to slow down. The heart's going to be. Okay. Beta blockers act on SA node, AV node, slows down the conduction of the heart.
And that would decrease cardiac output?
That, well, it depends. It not necessarily. Because if you use, remember, the heart gets filled during diastole. If you have a heart rate of 70 per minute, you have boom, 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 boom. But if you have 140, what is the time for filling? No time. So maybe the cardiac output is very small because it's not getting blood. So as you slow down, you increase the filling time, and you have more time. Okay, we fill and you increase the cardiac output. So it will depend, okay, on other things. And well, this is talking about the role of calcium and ATP. And this applies not only to cardiac muscle, this applies also to skeletal muscle. Okay, this is the cycle or the contraction cycle of the striated muscles, is cardiomyocytes in this case, but this also applies to skeletal muscle. Remember we were before talking about calcium entering in the cell, interacting with the ryanodine channels in the sarcoplasmic reticulum, calcium being liberated from inside the cells. Now we have calcium binding to troponin. See the three troponin, TIC, calcium binds to the C. And that will make tropomyosin move away. Okay, from that position will allow the interaction of actin and myosin. Notice that there are molecules of ATP on these myosin heads. ATP is there, ready, okay, to be used. Okay, then we have, after tropomyosin moves, we have the myosin heads binding to actin, and notice what happens with ATP. It's broken into ADP and phosphate. Phosphate is there. Okay, that union of actin and myosin is what we know as cross-bridge formation. Okay, you have the actin, you have the myosin head, and they interact. Okay, that is a cross-bridge formation. Now, if you move to number 3, we have what we call the power stroke. This is the actin and the actin and the myosin head. It's going to do this. It's going to pull. Okay, that is the power stroke. Notice that now, what is happening? The ADP and the phosphate are released. This ADP is going to look for another P to form a ATP again. Okay, and this union between actin and myosin is not going to be liberated unless you bind an ATP there again. Okay, so ATP is necessary for the detachment, okay, for the weakening of the bond between actin and myosin. So what happens, and let's try to go to the example of the skeletal muscle. What happens because of lack of ATP? Muscles can contract but can't relax. Can't relax. That's why when you have a person who died some hours ago, they have fever. Because all the actins and myosins are like that. That's why if you eat meat from a cow that recently was killed, you have to use the pressure cooker, right? Man, like 1 hour. It's impossible. You have to wait. Leave it there, like 3-4 days. It starts getting green. That's good enough. Right? Right, you don't have to spend that much money to have good meat. You leave it there 3-4 days and you see the edges getting greenish.
Self-intended.
Right. So actin is released with ATP. Okay? Now, what is calcium necessary for? For contraction or for relaxation? Contraction. And for relaxation too. But in this case is the no calcium. Okay? While calcium is there, that's going to continue happening. If you need to not contract, let's say, oh, the heart is on strike. Heart doesn't want to contract anymore. We'll send all the calcium to the sarcoplasmic reticulum. We'll send all the calcium to the outside, and no more contraction. Okay? How do you send the calcium to the sarcoplasmic reticulum? Do you think you need ATP or not?
You do.
Yeah. Sarcoplasmic reticulum has a lot of calcium, and it releases just 1 microgram there. You have to take it against the concentration gradient back. So you have an enzyme that is called the sarcoplasmic reticulum ATPase, or SERCA. Okay, sarcoplasmic reticulum ATPase is the enzyme that, so we need ATP also to move the calcium from the cytoplasm into the sarcoplasmic reticulum, okay, and to take, of course, calcium away and finalize the contraction of the heart. Now, the nervous system has to control all this. Okay, and we already studied in autonomic nervous system, okay, the activity, the actions of the sympathetic and the parasympathetic nervous system. Okay, how they, for example, stimulate or increase the heart rate or decrease the heart rate. Okay, notice that the sympathetic postganglionic fibers that arise from levels T1 to T5 innervate SA node and AV node and the ventricles. Everything is innervated by sympathetic fibers, but the parasympathetic fibers from the cranial nerve number 10, vagus, that also is for the gag reflex, gag reflex, okay, innervates the nodes only, SA node, AV node. Okay, there is no parasympathetic or very minimal parasympathetic innervation to the ventricles. Okay, so if you simply want to create stronger contractions, you increase the sympathetic stimulus. If you want to make it not so powerful, you decrease the sympathetic stimuli. Parasympathetic doesn't have too much activity on the ventricles. So you simply can slow down the heart by using parasympathetic innervation. So that means if there is a minimal innervation to the ventricles, you don't want to use a parasympathetic blocker to increase the contractility, the force. Okay, you have to stimulate the sympathetic nervous system. Or you can use digoxin. Okay. Who knows how digoxin works? It's a very interesting thing. Who knows what is the mechanism of action of digoxin? Digoxin is actually a poison.
Does it block calcium?
Blocks something, but it's not calcium. Those are the calcium channel blockers. This is the cardiac cell. Okay, resting membrane potential is minus 90. And threshold is minus 70. Did you get the mechanism of action of digoxin? The mechanism of action of digoxin is it blocks the sodium-potassium pump. That's what all you need to kill a person. Okay. Blocks the sodium-potassium pump. That's all you need to kill a person. because our life depends mainly on the sodium-potassium pump activity. Okay? What happens if I block the sodium-potassium pump?
The cells won't depolarize or repolarize.
No repolarization.
No polarization, period. Whether it be re or D.
No
How is it going to change the resting membrane potential?
It would be positive.
It would always stay negative, right?
There will always be
I
some
mean
leak.
positive because there's no repolarization.
What is going to happen is we are going to affect mainly the repolarization of the cells. Okay, so sodium enters and is not taken.
So it'll just.
Okay, you are going to have accumulation of positive charges. We are not going to move this. We are going to give a dose that elevates the resting membrane potential to, let's say, minus 80, then it's closer to threshold. So we are going to easily excite 5%, increase the contractility of the heart. Okay, it's a medication that we have to be very careful with, because if we make a mistake with the dose, okay, patients can die. Okay, we give too much.
You said it increases the contractility of the heart overall.
The force of contraction.
What the documentary about the good nurse?
Yeah.
If the good nurse used that
Yeah.
dose?
But they use it a lot in ICU, so if
Oh,
they're
yeah.
gravely ill, they use it to increase the
Yeah, increase the contractility. Because we could, for example, we could use epinephrine. Yeah, but the problem is epinephrine also produces vasoconstriction. So you are increasing the contractility and constricting the blood vessels, increasing the blood pressure. So I'm not getting anything, and I'm constricting the blood vessels that go to the brain. No?
Are
Or
there
the kidneys are.
any like vasodilators that are not parasympathetic?
You could use dopamine as well, but dopamine can be used in emergencies. You don't use dopamine in the long-term treatment. Okay, dopamine can be used in an emergency, in patient who is in shock, patient who is bleeding, patient who is, okay, for a while during surgery or emergency, but not take dopamine every 8 hours or daily.
Can you explain how it affects repolarization?
Accumulation of positive charges inside the cell. Okay, sodium enters and is not taken out. So the inner membrane becomes less negative. It's not that it becomes positive. It goes a little bit above the normal. Okay, comes closer to threshold. Okay. So here we have some concepts, okay, that we are going to be using in the future, and you're going to be using a lot in pharmacology. And this has to do with the effects of medications and the effects of neurotransmitters of the sympathetic, parasympathetic nervous system. Okay, we can use neurotransmitters or medications that have a positive chronotropic effect. Chrono means time. So positive chronotropics are going to increase the heart rate. Norepinephrine, for example. Okay. There are medications that are dromotropic. This dromotropic simply means increases the conduction velocity, okay, in the AV node. Okay, this is one of the things that norepinephrine does. We have inotropic medications or neurotransmitters like epinephrine, norepinephrine that increase the contractility. Like the oxytocin, but we are talking here about the autonomic nervous system. And we have lucitropic, okay, that allows a faster relaxation after the contraction. All those are effects of beta-1 receptors when they are activated by norepinephrine or norepinephrine. Okay, so if we block the beta-1 receptors, we use a beta blocker that is non-selective, we are gonna decrease the heart rate, we are gonna decrease the conduction through the AV node, we are gonna decrease the contractility, and the relaxation is not gonna be that fast. It's gonna take more time to relax. Okay, parasympathetic neurons, to the contrary, they activate muscarinic receptors. M2, remember I told you M1, M2, the rest of the body has M3, M1, M2. M2 receptors Okay, and has only one effect. That is easier, negative chronotropic effect. So the only thing that is going to be affected is the heart rate. Because remember, the contractility has to do with the contractile fibers. And the contractile fibers have no or minimal parasympathetic innervation. And also, the relaxation velocity is the contractile working fibers that have minimal innervation by the parasympathetic nervous system. So it's going to affect only the heart rate. Okay? And this simply is representing exactly the same thing, vagal stimulation, sympathetic stimulation. Remember, there is no moment when they are on or off, unless you cut the vagus nerve. We can produce that, cutting the vagus nerve. Yeah, of course, now the parasympathetic is off. But typically, physiologically, they are interacting. Okay, the SA node has an intrinsic rhythm. It's around 100 per minute. That's different in every person. Okay, parasympathetic lowers the rhythm, is what maintains our heart rate as we consider normal, below 100. Okay, from 60 to 70 average person. Okay, medications can alter the pacemaker activity. And you have different factors there. Digitalis is one of them that inhibits the sodium-potassium pump, okay, maintaining the heart in a state of slight depolarization, okay, increasing making this less negative inside the cells, okay, that also will maintain more calcium inside the cells, okay, leading to increased force, okay. But then we have also hyperkalemia. Okay, hyperkalemia effect on the heart has a very complicated effect. It's a question that I've seen several times in question banks, no? What is the effect of hyperkalemia on the heart? And just remember that the rate of diffusion will depend on the concentration gradient. So let's say that potassium, if you open the potassium channels, it will leave at certain speed. Okay? But one of the determinants of that is, of course, the number of channels, but also the difference in concentration. Let's say that normally there is a difference from 100 inside to 1 outside. If suddenly you have 100 to 20, now the gradient is lower. Okay, so potassium will have more difficulty moving out because there is more outside. Okay, so when you have excess potassium outside, you're going to have excess positive charges inside the cell. Okay, so we are going to have something similar to what happens here. Okay, the resting membrane is going to be closer to threshold, but I say this is complex because potassium outside the cells also inhibits sodium channels. So even though it is closer to threshold, sodium channels are inhibited. So sodium is not going to enter. Okay, it's a very complex process. Hypoxia produces bradycardia. Okay, we don't have ATP. You don't have oxygen, you don't have ATP. And if you don't have ATP, the sodium that comes in stays in. Okay, and in this case, it's not some of the sodium-potassium pumps that are blocked, as if we use digitalis. If you don't have oxygen, you don't have any sodium-potassium pump working. So you have tons and tons and tons of sodium inside the cells. So that will produce cell depolarization, suppressing the depolarizing current. Okay, mind that you have so much sodium that the potential, instead of minus 90, is 0. Zero potential means zero difference. The battery is off. You have to go to Home Depot and buy a new battery. Or to the ICU and have or OR and have a new heart. Okay, because in that moment, when the potential is 0, there is no possibility of contracting or transmitting anything or doing anything. And that's going to be all for today. Okay? Yeah, we're going to go. Is that here?